in sound of today.
Hi there and welcome back to Tap the Art of Physiotherapy. I'm Joel Kriska, sport physiotherapist. Today we're going to talk about a bizarre injury. It is one of my favorite injuries, which sounds weird, but when you see enough of them, you start to appreciate how cool this particular injury is. But what we're going to look at is a sprain to the superior tib-fib joint. So looking at the model here, it's right at this one spot. Okay, so this particular injury, it's such a bizarre one because it masks itself looking like a meniscus injury. So in jiu-jitsu, we're gonna see it commonly happen with heel hooks, or even if just someone falls weird, but the mechanism again is sort of like a drop in, like a planted foot and the knee drops in, or any kind of end range external or internal rotation of the tibia on the femur. Now, what's really interesting about this particular injury is people assessing it without paying attention to it will automatically assume that it's a meniscus, because one of the major tests that we use, and there's lots of them out there, but one of them that a lot of people use clinically to look at meniscus injuries is what's called McMurray's test. And that's basically, we're gonna fully flex the knee and then externally rotate or internally rotate. And a superior tib-fib sprain will, first of all, it doesn't like fully compressing. Essentially, the fibular head gets yanked into a posterior direction, and so that when we bend the knee all the way, it's as if it's sort of in the way. Right? So I'm bending the knee and this little joint is not moving forward out of the way as I bend it. And you can differentiate that between a meniscus tear and just a regular superior tib-fib injury is if I bend the patient's knee and then I pull that fibular head forward, the pain goes away. Okay, so number one is if I bring my heel to my bum and it causes pain on the outside of the knee, and I pull that little fibular head forward and the pain goes away, the likelihood of it being a meniscus injury starts to drop, and the likelihood of it being a superior tib-fib sprain goes up. The other characteristics that come along with this superior tib-fib sprain, which I find is just fascinating, is it will cause weakness of the popliteus, and I have a video on that, so if you don't know about how to check for the popliteus strength or how to strengthen it, check out that video. But essentially what it is this resisted internal rotation of the tibia on the femur. So again, when my foot's pulling inwards and I give it resistance, someone with a superior tib-fib injury will not have any strength to do so. They will also be weak in ankle eversion, right? So I'm pulling my foot towards my pinky and the muscles are here on the outside, the peroneal. And the last one is weakness in the hamstring. But interestingly enough, it's weak in a 90-degree position. So this is typically like the power position of the hamstring. But what's neat about this is that if you look biomechanically at it, the hamstring is pulling directly posterior this fibular head in this position. So as I tighten up my hamstring, it's pulling the fibular head posteriorly. And that's the way that the injury has occurred. So it's almost like it's amplifying the sprain of this superior tib-fib. And the fascinating part about this particular injury is that if you see a weakness of all three of those, the popliteus, eversion, and the hamstring at 90 degrees, and we pull that fibular head forward and they all become strong once again, then we know that first off, it's not a weakness of those muscles. It's an issue with stability of the superior tib-fib joint. And once we provide proper stability of that, the muscles regain normal function and you get full range, full strength, less pain. So the neat thing about this superior tib-fib joint is that we are not now concerned about the strength, we're not concerned about the range of motion. What we have to then decipher is this superior tib-fib joint moving too much or too little? And what I mean by that is, in the process of the injury, did the fibular head get sort of pulled and jammed backwards into a posterior position? And if so, we have to mobilize that and get it moving again. Or did we actually injure the ligament between the fibula and the tibia, and now it's hypermobile? And if that's the case, we have to stabilize it. The best way to stabilize it is with tape, because there's no brace that really works properly around this high fibular head, because it ends up cutting off circulation and compresses the common peroneal nerve, and we don't want to do that. So I'll make another video of how to properly tape it, because it really does feel good. It's the difference of walking without pain and functioning without pain, and you take the tape off and it feels like you're unstable and weak again. So that's for the hypermobile. For the hypomobile, essentially those are the ones that, again, they are stiff when we go all the way back. They feel better when we drive it forward. And there's two ways to do that. Clinically, you can, if you have a patient, you can ball up a towel roll, and we want to get that right behind the fibular head. So I'm just gonna make a little ball here. We take this little ball and put it on the lateral third or lateral half of the calf, and then we're trying to forcibly bring the ankle to the bum. And that fulcrum drives the fibular head forward, getting a manip of the joint. And that's where the person just goes, oh my gosh, I can move. You check the strength of the popliteus, the everters, and the hamstring, and they're all strong. If that doesn't work, or they're really apprehensive to do a manipulation, they can do it on their own. So again, they take the same towel, they place it under that lateral third, or right behind the fibular head. It's important that you don't go right across, because you don't want to be here and then fully flex. In theory, you could injure the ACL, especially if they're recovering from an ACL injury. So we just want to, again, like, get it behind the fibular head, and they can either do that motion themselves, like in an oscillating fashion, or they can go into a bit of a lunge position where they're driving forward. And as they drive forward, bringing the heel to their bum, that towel fulcrum just mobilizes that fibular head forward again. Okay, and then the strength stuff that we want to work on, we want to get back into the basics again of doing the popliteus strengthening, which I have a video on. If you want to watch that, go ahead. And we also want to work on regaining ankle eversion. So basically the three movements that we want to strengthen are the ones that were impaired from the actual injury. And the last one is strengthening the hamstrings. Now we got to be a little careful on this one, because we don't want to be strengthening it where we're bending the knee to 90 degrees again, because again, if the hamstring is part of the reason why it happened, where it pulled that fibular head posteriorly, I don't want to be strengthening into that 90-degree position. So you can work on the good mornings, or like little flutter kicks, or just making sure that you're doing hamstring curls, but we're not getting to 90 degrees. After a couple weeks of getting stronger and the joint's mobile and everything's feeling good, then we can get back into doing some of the hamstring curls, that, like, say, the hamstring on the ball exercise. Again, if you look at the video that I put out on bulletproofing your knees, there's a great example of how to work some of the hamstrings. But just make sure that you start in a straight leg position, like the good morning, because the hamstrings are pulling superiorly, and that's fine. We just don't want to get them in that 90-degree angle. And one of the things I forgot to mention is a telltale sign with a superior tib-fib injury is you go to, like, pull your own shoe off, and the hamstring pulling on that fibular head hurts. So if you made it through this whole video and you still aren't convinced that you have a superior tib-fib injury and that was a symptom that you have, I highly recommend you go see someone about it and get them to assess the mobility and the strength around that area and help to get you functioning back again. A word of caution is that for significant knee injuries where the superior tib-fib is involved, you can still have a meniscus injury on top of that. I by no means am saying that it's sort of exclusive one or the other. And I think it's probably more common than not where they're both involved. But I guess what I'm suggesting is that for some of the meniscus injuries out there, perhaps we've just been looking at the meniscus injury and not looking enough at the superior tib-fib and its impact on the stabilizer muscles, the popliteus, the peroneals, and the hamstring. And so again, if you're recovering from a meniscus injury and you're finding that it's really hard to develop strength around the knee, perhaps we have to look at mobilizing that superior tib-fib joint and regaining muscular control on the hamstrings, the popliteus, and the peroneals. I hope you've enjoyed that. I will see you on the mat soon. Thanks again.